pathogenic organisms. And most of us woke up this morning with smooth skins because Bacillus subtilis did not sleep. It was moving around, destroying the mold that would have woken up covered with. So that's how important microorganisms are to us. But in certain instances, they have been primed to evolve to defend themselves. They have all mechanisms, they have molecular mechanisms, and they communicate to each other more frequently than we think. Through quorum sensing, they share lots of information, and therefore they evolve to invade our arsenal that exists, the antimicrobial agents. And when we talk about antimicrobial resistance, we are mostly tempted to think about antibiotics. Last week I had a lady who was on antibiotics. She came back to the lab and said, no, I still have a problem. I think I need more antibiotics. But she had a stubborn candida called Candida cruzi, which is notorious for causing antifungal resistance. So whereas we talk about antimicrobial resistance, let's think about antifungal resistance. Let's think about anti-helminth resistance, antiviral resistance. All this makes what we call antimicrobial resistance. So that is very important. And then today I will speak more towards the One Health approach. So we need to come together as a team and address this problem collectively. The problem is we are trained in silos, and therefore we practice in silos. So everyone thinks they are best at their field, but if we came together, we were better together. 65% of the diseases we treat in hospitals come from animals. So why don't we have vets in this house addressing with us the same problem of antimicrobial resistance? So that is important that we address this problem together, collectively, so that it's tackled at all corners. So working in silos is not going to help us solve the problem, because the problem is bigger than what we see in the hospital. When we receive patients in the hospital, they already have the problem. They probably got that problem from the community. So we need to get back to our communities and see where is the source of this problem. Is it the water people take? Is it the juice in the caveras? All these are actually sources of this problem. So AMR is a global challenge. Mortality is expected to, and morbidity is expected to rise, and about 700,000 people are estimated to die due to resistant infection. Not only resistant bacteria, resistant viruses, resistant fungi. Yes. So all that is expected. By 2050, 10 million lives a year will be lost, and there's a prediction of 10 million annual deaths. 80% are expected to be in the low and middle income countries, where we belong. And I know this prediction is better than the prediction of COVID. The prediction of COVID is that we would have nowhere to bury people in Africa, but the reverse was true. But there's a very big problem in Africa and in Uganda. There's already high resistance to commonly used antibiotics. A lot of information in the hospital has presented a lot of antimicrobial resistance. Though very little information is coming out from the veterinary side, we need information come from the environment. We need information come from the food industry. Now, when you look at the sewage of Mbale, how it moves, it gets to Nabuyonga. Yes? From Nabuyonga to our vegetables, when you go and buy these very nice vegetables, it's actually that gray water. And we sometimes blame Karamoja for opification. But if you go to those draining channels, it's where the street kids defecate. Direct, they go to Nabuyonga. From there to your veggies and to your mouth. So that's how big the problem is. Yes, so a lot of cost is attached to antimicrobial resistance. And 300 billion dollars to $1 trillion annually is expected to be spent on antimicrobial resistance. And AMR is expected to elevate the rate of poverty, and this will directly impact the low and middle-income countries, and our GDP is going to be affected. And actually, we know, I was there actually at the time I treated malaria at 500 shillings. Right now, what is the average cost of treating malaria? It is around 35. Chloroquine would sort malaria. Chloroquine of 500 shillings would sort malaria. And now, on average, we need about 35 to recover from malaria. It's worse when it's a child. You could actually even spend more. So, and that's how expensive antimicrobial resistance is. And the problem we have is that the speed at which antimicrobial resistance is developing is faster than the speed at which we are discovering the drugs, the antibiotics, the antifungals, the antihelminth. The speed at which these resistances are developing is much faster than the speed at which we are developing new drugs, new molecules for these antimicrobials. You can look at those golden ages where there were so many antimicrobials being discovered. But you know, from 1955, it dropped. The number of antimicrobials being discovered are very low. And from 2020, from around 1990 to 2020, there was almost nothing until we have recently a TB drug, anti-TB drug developed. Next. So when you look at this, the moment the antimicrobial agent is discovered, 2 to 3 years later, antimicrobial resistance is recorded. So that is that fast. And then the speed at which we are getting new antimicrobials is so slow. First of all, the process is very expensive and time consuming. It takes a lot of time to discover one effective antimicrobial. But the organisms quickly adjust to resist that antimicrobial. So we have had some of these antibiotics modified, but no new molecules are actually coming out. And when it's true that when you modify an antibiotic, it could be more effective, but it also means the bugs can quickly adjust to resist the same antibiotics. Because you've been introducing a similar molecule to these very organisms, then they will quickly adjust to resist these antibiotics. So the speed at which development is happening of resistance is very fast. And now we have a lot of information from the clinic showing us how much resistance exists. But our friends from the vet side, there's very little information coming in. Some information has begun to drop in, but how do we make use of this information? And moreover, how many, by show of hands, have never taken ARVs? Show of hands. Mine is down. You've never. Yes, I'll tell you the bad news that ARVs are given to chicken in all our villages. They give them to chicken, they give them to pigs. They help pigs with these viral infections. And there is also always swine fever, which is very common in pigs. So you might say, okay, I don't eat pork, but you eat chicken. Chicken are also given these ARVs. And when you ask them, where do you get these ARVs? It is us, the health workers. Either they give them the expired ones or whatever, but anyway, that's where they get these ARVs from. So at some point, we have all taken ARVs, including myself. And by the time I get HIV, I will get the one which is well prepared. Because already I've taken ARVs and they may actually not be very important. So that's the extent of abuse that is existing. Animal feeds have additions of antibiotics. Even cows, they are given antibiotics. When you go to Western Uganda and follow the cattle corridor up to Karamoja, animals are treated by anyone and everyone who is not trained. When you ask them, where did they get the knowledge? From their judges, from their fathers. Yes, these people are amazing. When I was in Western Uganda, they know how to tell how a cow has headache. They will describe to you how a cow will start hitting the ground. And they tell you, no, the cow has a headache. And what do they give? They give action. Do you take action? Yes. And they have also used those veterinary drugs on humans. We might say that these people are using human drugs on animals, but animal drugs are also being used on humans. So that kind of use, there is a lot of overuse of antimicrobials in the animal sector. So that is very important. Now when you have a mix like this, this was Queen Elizabeth National Park. Who knows that blue thing, blue and white? It's a sassafly trap. So actually in that environment we have sassaflies. Sassaflies feed on the wild and the domestic. Only the domestic are treated all the time and every time, but by untrained people. No one treats the wild. They remain as a stock. So there is a lot of pressure on antimicrobial use on domestic animals. And then that drives the evolution of antimicrobial resistance. I interacted with one person who was treating animals, and I was surprised. They told me that the dogs also suffer from malaria. So that is what is happening out there, and the drugs are used here and there. And some of our communities, we live communally with all these animals, the wild and the domestic. If there's anyone from Renshama, I took this photo from Renshama, and you can see goats grazing with the buffaloes, and the elephants grazing the same place, and the cows, and they share water. And there is evidence now that these shared resources are acting as mixing pots for antimicrobial resistance. So this kind of close proximity, close association with animals is giving us more trouble in antimicrobial resistance. Grace, some of you might have watched Grace on TV. She was a lecturer like me, and she's now a farmer. I think I need also to graduate to that. She took this photo last year, and she's a goat farmer. But you see how close she is with her goats. Yes? And this is just not a close association. We are exchanging bags with these animals. And remember, Grace is not a doctor. She treats these animals, and then she associates with them. And therefore, there is this pressure for evolution of antimicrobial resistance. Those bugs will be forced to evolve to resist microorganisms. I took this photo in one of the landing sites in Kasese. You see the cows are taking water, and they do these things simultaneously. They are taking water while defecating. And the children are swimming, and the ladies are fetching water for domestic chores. This happens in our community. And therefore, all these shared environment and shared resources have become mixing pots for antimicrobial resistance. So this is the breeding ground, the very reason that we need a One Health approach. Who is concerned about the landing site? Apart from picking fish, and that's all. Yes? And there's also very high HIV rate in this landing site. I was surprised that ladies sell themselves in the day, and they bargain with the fish. They bargain the fish and they add their bodies. So that's the total cost of the fish. So this happens. So when HIV comes with its infection, with its elements, then it is going to be, you're going to be on medication literally most of the time, and it will drive the pandemic. In one of these findings, when we did this, actually the rate of resistance in humans is similar to the rate of resistance in animals. So it is surging from the animals, it's coming from the human, it's coming from the environment. In one of the projects that we are that we have proposed to NIH, it has gone to their one stage. If we get it to, we'll be lucky. But we are trying to construct a wetland to be able to remove antimicrobial genes from the wetland, such that it doesn't come back to circulation through animals drinking or ourselves consuming this water. So we need new innovations that will rid the environment of antimicrobials. So there's big patterns. A lot of antimicrobials have been are now resistant. So in this analysis specifically, we only found that cotrimoxazole, there was a difference in resistance between cotrimoxazole in human and animals. Because by then, there was very little use of cotrim in animals. But now I've seen increased use in chicken. Everyone is called, is it trimoxole? It's very common in any chicken farm. And every time the chicken are actually feeding on food and are feeding on antibiotics. So even a person who has not gone to P1 knows that you must have an antibiotic in the chicken drink. So that is what is happening. So at the human-animal interface, there's a lot of transmission of antimicrobial resistance. There's a movement of AMR from humans to animals, animals to humans. Then we all share it to the environment, and we go back and pick it from the environment. And all this transmission needs to be broken. How do we break this cycle? It means these decorative infection prevention committees that we have in our facilities should wake up, so that we can try to break the chain of infection. We must break the chain if we are to break through. If we are to break through, we must have to break the chain of infection. I'm just flashing all those antibiotics that are resistant, and this time is only cotrimoxazole, which had a different resistance. Now, when you look at the resistance patterns from animals and humans, they are pretty similar. The ones that have surged in humans and in the animals, they have a very similar trend. So we are saying, why not work together? Yes? Why not train together as opposed to being trained in silos to address a problem that we share? And if 65% of the infections we treat in hospitals are coming from animals, is there more reason to have these veterinary personnel work with us very closely in a One Health approach. So that is very important. And if we prevented these infections at the community level, then we'll have very little work to do at the hospital level. The work is the other side. The work is in the community, the work is in the environment, so that we make our environment safe for all of us. I traveled to Germany, and I took my malo from Uganda. I was in a room. The first day I was given sparkled water. I took it, I didn't like it very much. Now I was waiting to get water to drink, not knowing that the other people just get a glass, go to the tap, get water and drink. We have not reached there. Before the water reaches the tap in your house, it has crisscrossed with sewage pipes, and we in one of our projects we have recovered so many bacteria in tap water, which is treated. So we have not reached there that we have safe water. Even when we are saying we have safe water, the tap water, it is contaminated. Some of those pipes, those metallic ones, are of those days, rusted, mixed with sewage, and on average, if a tap bursts in your community, it takes about 2 weeks to fix. So in that, there's a lot of mixing of microbes with our water, making our water unsafe. And we have seen shared genes between human and animal microbes. And that is more evidence of cross-transmissibility of these organisms from humans and animals. We can no longer define the directionality of spread of AMR because it seems to move to and fro. Yes? Moving from humans to animals, back to humans, to the environment, and we get it back. So there are so many shared genes. When you look at the beta-lactam genes, the chloramphenicol resistance genes, the efflux pumps, we have recovered them in organisms that are from animals and from humans. So that presents a great danger that we need to come and reason together. Actually, I've read the Bible and says, come and we reason together in Isaiah. I think we need to bring it to the practice in medicine that let's come and we reason together. Yes? Not the surgeon alone on the other side, the physician on this side, then someone, an ophthalmologist this side. And recently we have seen an increase in trends. We are isolating Streptococcus viridans in eye infections. So if we are getting more strep viridans from eye infections, where is it coming from? So we need to come back, to come to one table and reason together, such that we will be able to solve this problem. This one is a master's student of public health. He's looking at sanitation, hygiene, and carcass contamination with the E. coli 0157H7, the one we are talking about, enterohemorrhagic E. coli, which actually causes aggressive disease in humans. And we actually found that meat at the butcher that you can buy, 16%. There's 16% chance that you buy it with enterohemorrhagic E. coli. And this is the pattern of resistance of the enterohemorrhagic E. coli, and this is done in Iganga. So this is not in the US, it's in our community. This is done in the Iganga. Each time you go to that butcher, you are buying, you have a chance of coming with enterohemorrhagic E. coli, and most of it is resistant to ampicillin. And there is a surge of resistance to the carbapenems. the ones we would call our last arsenals. So you find that we are literally getting disarmed each time. And then we'll reach a season where small cuts and wounds will be very dangerous, because that will take us back to the pre-antibiotic era, where any surgery became very dangerous. So this is happening in our community. Even when we get out there, this is not hospital data, this is from the meat you buy at the butcher. You get into enterohemorrhagic E. coli, and it could potentially become a very big problem. So, Uganda's response to AMR, something has been done. It may not be satisfactory, but something has been done. There's an action plan, it has been reviewed. Unfortunately, I'll disappoint you that it has been reviewed before it was used. I wish it was really functionalized and used. Maybe our progress would have been much better. And there are many isolated projects that have worked on AMR, surveillance. We've had a tour. I was part of a tour project. There's a drum project, and the Fleming Fund has been funding a lot of these activities. And then the One Health approach, which is still less practical. When the One Health approach came, the vet people got in, and the medical people shied away. We are not working together. We need to come back and reason together. So the One Health approach requires functionalization. And when we functionalize this, we'll be able to solve problems with AMR. And most of these problems, most of what we have done now, and all those projects, and the upcoming projects, are still bent on finding the solution. But we have already found this solution. There are very few projects that are looking at solving the problem. We now know that AMR is there. So what? How do we solve the problem? So most of these projects have been bent on finding the problem, emphasizing the problem, but current efforts are just still geared to finding the problem, yet we have seen it. What solutions are there? So I appreciate a number of projects that have at least were tickled by COVID. I am in a group with the Barara and Moni and Cavalry, and we have 5 prototypes of antimicrobial agents. They are prototypes, they are not drugs. And by the time they become drugs, even the microbes could have developed resistance. So that's how fast development of antimicrobial resistance is. I'm happy with the NAPRIC project. It's doing quite well. Unfortunately, if we don't wake up as a country to fund our own innovations, drug development, we'll get nowhere. No white man wants to hear that the HIV drug was discovered by Uganda. So very little funding, external funding will come. And the day STI says we are closed, then everything will go down. But each one of us here are champions to encourage the country that we can do it ourselves. We can develop our own drugs, co-attend, and it is shared among family members. You take half. So, how many of us even finish these doses? How many of us in our community even have the purchasing power to buy these drugs, to get a complete dose? So, we are also faced with that poverty AMR dilemma, that you find someone cannot afford the dose of an antimicrobial, and therefore ends up taking just a bit of it And those suboptimal doses is what the microorganisms need to prime it to develop resistance. Remember, we are the biggest consumers in Africa. That I was from Africa, and Uganda was number one. Should we clap for ourselves? Yes. So now, look at this. Looking at all these categories of people, you look at severe poverty, and then the different people, then the vulnerable to poverty and not deprived. All the same, consumption is high. There are those that don't complete doses. And all those are direct drivers. And this is East African data. Uganda, Kenya, and Tanzania. We are directly faced by the poverty, AMR, dilemma. So all that, when you ask me at what stage of the cliff are we, I will tell us that we are at the edge of the cliff and actually about to fall. So we all need to wake up to the challenge and fight the pandemic of AMR. Thank you very much.